You should be able to see my slide, Rainer. Can you see
Yeah,
that?
I see your slide. So I think we're live now.
Okay.
Thanks Subodh for coming. I think you're always traveling the world and running the world. I know.
You should be able to see my slide, Rainer. Can you see that?
I see your slide. So I think we're live now.
Okay.
Thanks Subodh for coming. I think I just have to switch off something. Anyway, give me a second. Okay. Sometimes I get an echo here, which is a bit annoying. Right, Subodh. If you can hear me now, and I would like to say Subodh is a good friend. He works in Derby. He is great in education, and recently, or a couple of years ago, became a professor. And he's working all over. He is, and I think most importantly, he runs all the marathons in the world. And if he's not running at the moment and he's not working for his patients and education, he's now the Dean of the Royal College of Psychiatry, which is a great achievement. So, Subodh, I'm very grateful for your talk, Embedding Public Mental Health in Psychiatric Training and Practice, and please go ahead then.
Thank you so much, Rainer. And, again, as you said, we go back a long way, and it's been an honor and a privilege to work with you. And it's really great to see the fruits of your labor come alive, I think. And this is such a wonderful conference and such great speakers here. So really privileged to share the platform with them. Yeah, I think I think in many ways my talk follows quite well after Professor Sartorius's talk, because the point I'm going to make is that that we are attuned to be thinking of ourselves as doctors, as psychiatrists who treat individuals and individual pathology. And I really feel that that kind of narrows our scope, and I think it really makes us less potent as practitioners, as healers, as people who should be treating disorders. And I think having that public mental health approach, so thinking of us as doctors or psychiatrists who are not only responsible for the care of individual patients, but also for the care of communities, I think is really needed. And I think we need to really embed that in our training and in our practice and indeed in our academic education and research. So, well, thank you, first of all. I know that, a conference like this is not possible without the efforts of many. So, Rainer, thank you to you, but also to your team. I think Rohit, Daria, Sheshni, they all have been working very hard behind the scenes. So, thank you so much. I think I'm going to try and keep it brief. My slides may appear many, but I might skip some of them. And essentially, I'm going to try and make the case for the introduction of public mental health. I'll briefly touch upon what am I doing as the dean, and then hopefully also in the end, put a challenge to all of us in the room today to see what is it that we collectively can do, and then what might next steps be. And as you said, Rainer, this is an opportunity for a conversation, and I would really value that conversation and see where we go. So most people in this room, I think, will be familiar with Michael Marmot. Now, when I've gone and done this talk, across universities in the UK, certainly I find that there's been quite a variable degree of awareness about Marmot's work. Marmot first published his work more than 10 years ago, essentially outlining a thesis of how health inequalities and social determinants of health were absolutely critical to the outcomes of health outcomes for people. I think we all possibly pay lip service to this. So I think in the exams, if you got an MCQ, multiple choice question on how does poverty or how does poor housing impact on your likelihood of having a relapse with schizophrenia, we probably would be able to answer that question. But in practice, if you have half an hour with our patient, and Rainer, you and I both worked in Derby, and I think we routinely possibly discharge patients to inner city Derby in that Milestone House hostel, where we knew that people going into that hostel would actually increase the chances of relapse. And I guess I'm trying to challenge that kind of a notion that, well, are we actually thinking about those social determinants of health in our care planning and not? And clearly, I think the last couple of years, last 3 years have been quite a big, last 2 years have been quite a big, wake up call for us. I think COVID really shone a spotlight, reminded us that the world is a connected place. We can't really think of ourselves as being very disconnected with the world. We can't live in our own bubble. And I think COVID has really shone a spotlight. I think as the first waves of death started, we realized that there was a clear ethnic and an economic differential in the deaths, and that was reflected both in patients and in our workforce. And sadly, Rainer, as you know, that we from our own trust lost a member of staff. Now I'm sitting in India today, Rainer, as you said, I've come here for Diwali to be with my family, and what is true of UK is also true of India, I think. And I'm just going to talk about these two countries today, but the story is also true of pretty much every other part of the world. And I think the idea that you can somehow ignore inequality and just focus on our role as doctors and expect that health outcomes will somehow magically transform themselves to the best that they are is a fantasy. And I think we need to be invested in the inequality story if you want to make a difference. And tied to this is the story of sustainability, I think, which is a priority for the college. The Royal College of Psychiatry is one of our key priorities. And I think the reason for that is that this is an existential challenge for all of us. It's for the whole planet. This is a real challenge for the whole planet. And, sitting here in India, I remember growing up with my father talking about Vasudhaiva Kutumbakam, which those of you from India will realize that essentially says the world is one family. And we were brought up on this idea that the world is one family, it's a connected place. And I feel that it's really important that we internalize these lessons today, that the world is indeed a connected place. And what does that mean for our role as doctors and as psychiatrists is what I really want to focus on today. So these are my key messages today. I'm going to lay out the real evidence for embedding public mental health in our training and practice. And then I'm going to talk about Rainer, people like you, as to where can leaders like you play a role in taking this agenda forward across the world, especially in the global context, which is where this conference is very well positioned to make that impact. And indeed, the journal that we have too. So these are the various themes I'm going to be talking about. I'm going to talk about health inequalities first. So let me just start with that. When I was a medical student here in Mumbai, it's called Bombay at the time, we were promised that by 2020, the World Health Organization, we will have achieved social justice in healthcare. This idea that good health is biopsychosocial health would be achieved by 2020. And 2020 seemed so far away then that we really looked at it with rosy future, thinking that, well, this will indeed happen. And those rose-tinted spectacles have sadly, been replaced with dark glasses. I think 2020 has come and gone. And if anything, the polarization in the world has increased. If anything, all the outcomes that we've seen haven't really budged. Now, this slide tells a real story. People with severe mental illness die at least 2 decades younger. Now, we've known this for at least 35 years. And this slide is taught to psychiatric students across the world. In the UK, we've had several reports talking about this. And yet I feel it's just failed. We failed to make a difference in that mortality gap. And I think it's a question that we should be asking ourselves as psychiatrists as to how have we allowed this mortality gap to persist across the world? How has that happened on our watch? What is wrong with our training? What is wrong with our practice? What is wrong with our systems of care that this mortality gap has persisted? And I think that is the kind of hard-hitting question that we failed to ask. Another slide, I think, again, the science behind this slide is now very robust. We all know that as the number of adverse childhood experiences increase, the risk of negative health outcomes increases proportionally. We know that if you have more than 4 adverse childhood experiences, you are more likely to have negative health outcomes on a range of both physical and mental health disorders. So, 10 times more likely to have a suicide attempt, 4 times more likely to have depression, twice more likely to have cancer, 4 times more likely to have cardiac illness. and so on and so forth. So I think we know the science behind this is very robust. But even someone like me, I think, I did community psychiatry, I know you're aware, in Derby for many, many years. Would I have thought of this slide and this finding when I was managing my outpatients in Derby? I don't think so. I apologize for the firecrackers if you heard them in the background. Nothing dangerous, I can promise you. It's just Diwali. And I think the issue was that people with severe mental illness were presenting in my clinic, and I would probably ask them about their children, but I don't think that I invested enough in thinking about how can I stop the cycle that my patients' children were being set up for. They were being set up to experience a range of these mental and physical health illnesses in their life. And I don't think that I did enough to try and stop that. And indeed, even now, today in the UK, I don't think that our general adult psychiatry training is focused on that. Now, of course, as Dean, I'm going to try and address this, but the point I'm making is that systematically, I don't think this exists in our training. We don't see it as our role to intervene in these adverse childhood experiences early on in life. And yet we know that the figures are quite devastating. I think you look at this figure, which is about England and Wales, infant mortality by ethnicity, such a significant difference. If you're born as a white child, your infant mortality rates per 1,000 life versus 3.1. If you're born as a Black Caribbean child, the infant mortality rate is 7.4, Pakistani 8.5. So I think there's a significant variation there. Same in India. If you look at India, infant mortality ratios by wealth, by caste, a significant difference. You can start seeing that there is a significant difference that has sustained. Now things are improving, so it's all not pessimistic. I think certainly in India, as the overall GDP of the nation has increased, things have got better, but there's still a long way to go. And I feel that we have to internalize this and then be aware of this. And this is figures from US. So just to remind, this is not a story only of the developing world or not so rich nations. The richest nation in the world has such a big problem. At age 25, a Black man, his life expectancy is going to be 5 years younger, and that is after controlling for all other factors. So there is a significant problem that we have in health outcomes, and I don't feel that we've thought of it in that way. And I think inequalities, this is UK data. In the UK, we know that people of African Caribbean descent are 3 to 5 times more likely to be diagnosed as schizophrenia, more likely to enter the health system through legal routes rather than through GPs or through the medical route, more likely to be prescribed higher doses of medication, and overall access to healthcare is poorer. In Derby, where I grew up, I think my Muslim patients, my patients from South Asian backgrounds had far poorer access to psychological therapy compared to my white patients. And this is often systematized in the way institutions operate. And so in many ways, this slide is quite important. And if I ask you to remember one slide from my talk, this is it really. So this slide shows that the more unequal the country is, the worse are the outcomes on a range of outcomes. So if you look at life expectancy, infant mortality, homicides, teenage births, all of the outcomes are worse in unequal countries. And now I found that when I talked about workforce inequalities, often people would say that, well, yeah, so if you are a migrant to the country, then you face the disadvantage, but the residents don't. And there's a similar feeling that if you live in the UK, if you are white, if you are rich, then you don't really have to face the disadvantages that the people from African Caribbean background, Pakistani background are facing. This slide shows that that's actually not true. Inequality impacts on all of us, all of us. So just because you are rich, because you're white, it doesn't make you immune to the effects of polarization. And COVID showed us that, right? COVID showed us that it didn't really matter, I think, that you were living in a rich country. Countries like the UK, sadly, had a very, very high death toll. And, I think this slide, again, kind of illustrates that if you are comparing a billionaire living in Japan to a billionaire living in Kensington, London, UK, that billionaire living in Japan has a far better health outcome than the matched control billionaire in the UK. And I think this is something that we need to be aware of. And And now, right now, I'm in Mumbai, and I think you can see why. I think Mumbai is really illustrates this polarization. I'm surrounded by people living in high-rise apartments, some of the richest people in the world, and yet I think if they suffered a myocardial infarction, what might kill them is just the fact that they can't get to the best healthcare that is available in this country, in the city. Some of the best doctors in the world, some of the best hospitals in the world are available in the city, but they might not get there because the roads are so bad. The emergency medical care system, the ambulance system is not up to the mark. And so I think we have to see that health outcomes operate as a whole. It's an interconnected system. And this is again quite an important slide. I think it demonstrates how our health education has been structured. So typically, I think even our psychiatric curriculum is focused as if most of our psychiatrists will only see pure mental illness in their clinics. Now, this slide shows that a typical outpatient psychiatrist will only see about 5% people presenting with mental illness, pure mental illness in their clinics. Let's assume this is not completely true. This is from Washington State. In my case, maybe it was 15%. In your case, maybe it is 20%, 25%. But the reality we know is that bulk of our patients actually have a comorbid physical health condition or a comorbid substance misuse problem. Alcohol or drug problem is so rife. And yet our training kind of is preparing us as if we are treating people presenting purely with mental illness. And I feel we need to really change that. We need to think about how do we modify that. I'm not going to spend too much time on workforce inequalities. This is kind of specific to the UK, but I feel that it broadly equates elsewhere as well. And I think the point here that I'm trying to make here is that in our workforce, we need to make sure that it is diverse enough. The diversity of thought, not just the diversity of gender and race that people tend to talk about, but the diversity of thought is important. And so, again, a slide from India. I know Roy spoke earlier, and Roy has done some work in this area, where you see the medical school density of provinces and the infant mortality rate. And you can see that what shouldn't surprise us that where there is a higher density of medical schools, infant mortality rate is lower. And I think this is illustrative and shows right now I'm dealing with this issue because in the UK, we've seen this, that postgraduate training places are concentrated in London, and places like Lincolnshire, places like Scotland now, where you work, Rainer, the density of that postgraduate training places is less. And I think so we don't produce enough doctors for those areas. And I think how do we achieve that equality of distribution across the country is important. So I think we have to also think about not just producing enough doctors, but producing enough doctors in the geographical spread. And this is really very important in countries like in African continent, I think, where you see that rural areas pretty much have no coverage at all of medical cover, and all of the medical availability is often concentrated in urban areas. But this is an issue in the UK as well, and even that economic disparities is very obvious. So what is true of the UK, I think, is also true of India and many other countries. So 80% of doctors come from social class 1. Social class 2, 3, 4, and 5 together only make up 20% of the doctors. Now, you would argue that we have to become socialists, and do we really need that geographic, that economic spread amongst doctors? Well, I'm not saying that we have to become communists or whatever. What I'm saying is that by and large, we need doctors that can represent the communities that they come from. We need healthcare staff that can represent the communities that they come from. And if we don't, I think it actually has an impact on the health outcomes of the population. And then that's something that we need to bear in mind. So health systems are complex. And I think the more we understand that, the more we'll be able to design health systems that actually start producing results for our patients. And so let me now come to the meat of the discussion. So why should public mental health be an issue for all of us? It's not something, because hitherto, when you look at public health, I mean, we had public health when I studied in medical school. It was really a specialized topic. And even now, I think in the UK, people from public health sit somewhere else, and I don't really get to see them as a clinician. And yet, I think if you see that, unless you have a system that is operating on the principle of making a difference to the population where you're working in, your retention rates in those areas are poorer. People like to work in systems where they can actually see that they're making a difference to the outcomes of the population. And I feel that a lot of places, they don't invest in that kind of community engagement. And we know that actually when you put in that investment, you put in an investment to actually start making a difference at the population level, at the community level, then the experience of the staff is much better. They feel much better about themselves. They're more likely to continue working in those areas. So there's a real quality case. Now, I think if the case is so strong, I think why are we not doing this? And I find that a lot of people say that, well, of course, we are psychiatrists, we are psychobiosocial practitioners, we are doing this, we talk of psychobiosocial. I feel that I'm going to be quite challenging, and I'm going to say that what does psychobiosocial mean? I think, we probably use it as a loose kind of an explanatory model where we mix up saying that partly genes, partly your income, partly your housing, partly your psychological makeup, and that is it. I don't think that we actually use it concretely in the way we design our health systems, in the way we concretely design our healthcare delivery, and the concretely we actually operate ourselves in our outpatient clinics or in our inpatient environment. And so I think to say that we are already doing this, I would say is not quite true. The second barrier, I think, is that we assume that it's all the system's fault. I think clearly systems have not been designed to deliver that, but a lot of the barriers actually come from clinician attitudes. And I would like to really hear from all of you. So where do you see this? Because I do come across this quite a lot. And I think a lot of clinicians either feel that they are doing this, or some of them actually feel that this is not their role, that I trained to become a medical doctor. It's not my role to become a social worker. And I feel that even clinicians knowing the causes of inequalities is something that is very variable. I think when we've tested that in the UK, people have a very varying degree of understanding of what are the factors that cause and perpetuate health inequalities. I think my question would be that if you don't really understand the factors that cause and perpetuate health inequalities, how will you as a doctor, as a medical leader, start making a difference to this? And the clinician skills, again, I think people think that they are actually being person-centered care, person-centered and personalized in their approach. Because a part of this whole thing about public mental health is about applying that personalized lens, right? When a patient comes in, you are taking into account their individual story. Where is the background of the person? What is their housing situation like? Now, we all probably take that history. So I think we must feel justified that, well, we as psychiatrists actually take this history and maybe even come up with a formulation. But in reality, and from my colleague from London has done this work, and you find that actually not all psychiatrists do it at the same level. There are some psychiatrists who spend much more time in trying to understand the psychosocial background and the context of the person presenting to them compared to others. There are some people who spend far more time in actually developing that personalized treatment plan than some others. And it's not even routinely assessed. So for us to think that everybody's doing it is actually a misnomer. And in fact, Reeve said that he found a significant difference in the way people spend time, and he found that a lot of people were spending time in actually asking questions for assessment to establish the diagnosis, then in trying to establish a formulation. And that's something that we need to be aware of, that as psychiatrists, probably we are not paying so much of attention to formulations as we probably should. Now, this third fear, I think, is a real fear. I constantly hear, especially, I think I'm on certain WhatsApp groups across the world, and I think a lot of this comes across that, well, I don't want to become a social worker with a stethoscope. And I feel that, well, if you're a scientist, you really want to see what are all the variables that are impacting on the health outcomes of your patient. So to say that, well, I'm a medic and I need to know how to prescribe risperidol 4 milligrams a day, but after that, whether my patient actually takes it or doesn't take it is not my job or my business, I think is a little bit disingenuous. I think it should be our responsibility to make sure that our medical knowledge is actually translating to health outcomes for patients. And if it's not translating, why is it not translating? What are the barriers what are the barriers? Is very much our responsibility as well. I'll just take a little break, Ryan. I'll just have a sip of water, if I may.
You're welcome.
And I think this is now being recognized by our colleagues from the rest of medicine. I think as psychiatrists, we would have thought of ourselves to be the leaders of personalized medicine, precision medicine, because we thought of all the variables that might impact on an individual, clinical decision that we make. I feel that in our desire to be seen as real doctors, we have lurched towards a more narrow biological model, which fails to take into account other key variables that actually impact on health outcomes. While our endocrinology colleagues, our respiratory physician colleagues, our cardiology colleagues are actually getting there. And so this recent article in the BMJ talks about how statins, I mean, the numbers needed to treat for statins, I think you'll have to treat something like 30 to 100 patients with a statin for 10 years to avert one adverse cardiac event or death of a single patient. Now, if you are a GP and you got 10 minutes to the patient, then you have to ask that what should I use my 10 minutes for? Prescribe this a statin or actually spend time in discussing smoking cessation, which will have a far larger impact size in actually reducing the death of that patient. And this is not a remote example, because this is actually true for all of us. My earlier slide about patients with severe mental illness and cardio, and their deaths due to cardiac pathology, 2 decades, they're dying 2 decades younger. The single biggest factor that would produce that change would be smoking cessation. How many of us actually get involved in smoking cessation? I think very few do. And so the final thing, I think, if you start talking about social care, I think people start worrying that, well, what is public mental health, and is it too political? And I think I just remind people of what Lord Virchow said, that medicine is social science, and politics is nothing but medicine on a grand scale. I don't think that we can divorce medicine from the decisions and the systems of care that are used. And I think you can look at again the findings for India. Lakshmi, my colleague, I think very, very renowned colleague from India, and this is her article which says that the world spends such a high percentage of the GDP on mental health. India, on the contrary, is spending such a small amount. I think you can't then pretend that somehow that won't have an impact on the mental health of the nation. It certainly does. So where do we go from here? So for me, I think as a dean, I think it has been really drawing that explicit link that our education, our training is only as good as it actually produces outcomes for our patients. And I think that has to be a clear mantra, to say that, well, I'll go for this conference, this is our curriculum, all of that is good, but we have to go that extra step. It's not just about learning how to prescribe clozapine safely and effectively. It's also about learning, is my clozapine prescription making a difference to the health outcome of my patient? And how will I know that it has done so? I think all of that is our job. And I think making that is certainly my goal. And so for me, I think thinking about that, every system, if the system is constantly failing, if you're seeing that a system is failing to produce health outcomes consistently at a particular level, then we need to check, why is that weak link happening all the time? And I think I've given you some examples of the weak links. And so for me, I think unless my education training offer is addressing this weak link, it's not good enough. And so looking at health inequalities as a prism to see how good our training is, how good our health offer is, I think is the right thing to do. And I feel systematically, I think there has been an issue in the way we see ourselves. So I started with this idea, right? And I think we look at good medical practice, which is the professionalism document of the General Medical Council. Those of you who are familiar with UK will be familiar with this document. It's all about the doctor-patient relationship. There is no reference to the word community or population health at all. And so I think it's very much that we see ourselves, our medical education is very much geared towards treating individual pathology. Well, something's wrong with your liver. Let me look at your liver. Let me understand what is wrong with your liver. Let me assess your liver and let me treat your liver. We are not really concerned about what are the factors that might cause a relapse when the person goes back. You might think maybe it's too far a statement, maybe it's too generalized statement, maybe we do concern ourselves a little bit, but not in a systematic way. And I feel that holistic approach where we are interested in improving health outcomes is something that's certainly been missing. And what has been missing in good medical practice has also been missing in good psychiatric practice. And that's something we are addressing now in my role as a dean. So these are my top priorities. I'm just going to talk through each of them. I think so in terms of health inequalities, what I'm doing now is I've appointed a health inequalities fellow, and Cambui, who's a professor in this space in social psychiatry, has done a lot of work. He's a professor at Oxford. He and I will be co-chairing an expert reference group, essentially to answer the question that what is good practice look like in teaching public mental health to psychiatry trainees? What does good medical, good practice look like in assessing psychiatrists to see whether they've learned the lessons of addressing health inequalities and then public mental health? And clearly, this is about recognizing when you talk about personalized care, it's as much about neurosciences as about social sciences. So quite often talks about public mental health, about personalized care, kind of focus on the psychosocial. And I want to remind people that I want my trainees to be able to recognize when do you deviate from NICE guidelines? When do you, what is a scenario where you give somebody higher than, BNF recommended doses? When do you actually deviate from a guidelines? And then why do you do that? And I think all of that is really about personalized care. I think, so that's what we put in our new curriculum. So in the UK, the Royal College of Psychiatrists, we've got 7 curricula, 1 for core training up to MR Psych level, and then 6 for the 6 subspecialties, adult, old age, intellectual disabilities, and so on. All of those curricula have these key learning outcomes very much as a part of their curriculum. I think so. Things like health promotion and illness prevention in community settings, applying that knowledge that you have, understanding the causes of systemic and structural inequalities and intersections of it. So how does gender intersect with ethnicity? How does that intersect with poverty, and then so on and so forth? Understanding the social determinants of health, understanding the inherent power imbalance that exists between doctors and patients and healthcare systems, understanding of how people's characteristics may impact on clinical presentations, how the protected characteristics have that impact, how discrimination and racism has an impact on people's health outcomes, etc. And so for me, I think this is really about actually implementing this. So next year, we'll be looking at our curricula and our training courses and seeing how well are they training our future psychiatrists in these areas. And where we've taken a different approach to some other postgraduate training programs in the world. So a lot of the postgraduate training programs are talking about this, but they are talking about this only for a subset of the trainees, saying that, well, if you want to become a specialist in health inequalities, or if you want to become a specialist in public mental health, then we'll teach you these things. What we are saying in the UK is that, well, this is a core skill that every psychiatrist must have. You must know how to personalize the care that you provide to your individual patient by taking into account their individual background. And so that is where we are focusing on. So I've talked about the training course that we will be looking at, the gap analysis. We are looking at how do we bring in lived experience in training, because I feel that we learn best from our patients and carers along with our experts, professors. So I think bringing both of them is absolutely important. And so I've started this Dean's Grand Rounds, which is really about narrowing the gap between evidence and practice. And what we're doing here is we start with a clinical scenario where we know there is a gap between evidence and practice. So the very first Grand Rounds we had was about alcohol intoxication and withdrawal. We knew from evidence, national audits, that patients admitted to psychiatric inpatient units with alcohol intoxication and other disorders where there was a history of alcohol dependence, their withdrawal was not managed well enough on psychiatric inpatient units. So that was the gap. And so we had we wanted to narrow that gap. So we had 4 key elements. We had an individual talking about how their withdrawal was not managed well on an inpatient unit, coming and telling their story. Then we presented the national audit that illustrated how the data was very robust. It showed that the withdrawal was not being managed very well. So the third thing, I think we talked about that population health level data. Well, what is the impact of not managing this well enough, not just on that individual patient, but also on the wider health economy? What did it mean for the West Midlands wide health population? What was the cost in terms of mortality, morbidity, and actual economic cost? And then finally, we're supporting the quality improvement. So these are all efforts at trying to bring in psychiatrists to become responsible for the care, not just of the individual patients, but also of the communities. So I'm really keen on introducing assessments where we ask psychiatrists to think about not just case-based discussion. Rainer, you and I did a lot of case-based discussion. We were part of the same peer group. You chaired it so well. I think I want to try and bring in case load-based discussion where we think about what is the impact of our decisions, not just on the individual patient, but also on the catchment area. And then what are the things that we can do differently to improve the health outcomes for the whole catchment area. So those are the kind of changes we'll be bringing about. And I feel that this is where Mahmoud is now 10 years later. He says that we know the health inequalities are not inevitable, but we can reduce them. But sadly, in the last 10 years, if anything, things seem to have worsened. And I feel that we can change these things. I think where in Derby, we have involved our experts, patients, we involve patients in a very big way in the education of our medical students, in the education of our trainees. And we know that by doing that, we can actually bring about improvement, not just for our learners, but our patients also feel better. So I think it's a win-win. And I feel I'm going to try and draw this to a close by talking about what are the areas where we can start making a difference. So for academics, I really want us to start thinking in terms of the population level, starting to think of the psychobiosocial and what does it actually mean. So I think why has our research not focused as much on epigenetics as on genetics? We've got thousands and thousands of gene association studies, very few high quality epigenetic studies. And I really feel that we need to start thinking in terms of really starting to link, this idea that we can divide the world into, so we have this biological psychiatry and social psychiatry. And I feel that is such a false dichotomy. I think the reality is that it's all one. And I think we really need to start thinking in terms of, well, what does that one look like? And how can we actually fund research that starts answering those big questions in science and not just in psychiatry. And for educators, what this means, and I think we heard Professor Sartorius touch upon this, is that there has to be enough focus on social sciences in addition to neurosciences. I haven't touched on digital literacy, but I think digital and data literacy is going to be an important element. And I know we had a question on AI and mental health. And I really feel that if we ignore that, it will be a risk to the profession. And so, again, I, as a dean, have set up a task force on digital literacy in the curriculum. And that task force will report in 2023. And I want every single trainee to know how to use data about their patients, how to use data about their communities that they work in to start improving health outcomes. I think we definitely need to know, make sure that our trainees know how to formulate and how to deliver the personalized care. And I think we need to make sure how we assess them. And so as practitioner level, I think we have to see ourselves more than people who are just caring for the individual pathology, not just managing schizophrenia, but also managing the outcomes of schizophrenia for all the community that we work in. So that's where I'm going to stop, Rainer, moving from ideas to action, as always. And I'd welcome thoughts on how we can actually translate some of these ideas to actions wherever we are in the world.
Okay, thanks a lot. I'm really impressed with the quality of the talks today, and I really love your talk. Must say, inequality is one of my most social inequalities. So how do we get rid of social inequality without a revolution? So I do not know. So what is it what we have to do? And you have all these discussions at the moment at the BMJ about whatever CO2 in the environment. I think there's so many things. Do we have to go into the being politicians? Or I think you partially are now as dean, but I think. And the other thing, maybe you can touch this, and when you talk about inequality, what can we learn from the developing world in this? Because there's sometimes they might or might not have fairer societies. I leave it with this.
So great question, Ryan. I think the first thing is that no, I'm not saying that we all need to be politicians, but I think I do feel that our identity, what does it mean as doctors? I think that's something we need to look at, and I think. A lot of the time, doctors are trained to think of that, well, I know my science, and that's good enough. And I think, just to give you an example, when I was a doctor training in Bombay, just a few miles down the road from where I am today, I would start my clinic at 8 in the morning. Hundreds of patients would come in, they would queue up, not even queue up, they would just come and mill around. And some of my patients, I only got to see them at 2 in the afternoon. And I thought of myself as a very conscientious doctor. I thought of myself as a resident doctor who really cared about my patients. But not once while I was there in all the 3-4 years that I was working in that clinic did I think that, well, everybody's coming in. Why don't I set up a simple register so that they don't have to just wait there from 8 to 2? They can put their name down and then go and come back, have a coffee or tea, or come back, a bit later. And so I feel that it's those simple things about thinking of ourselves as not just who knows how to prescribe or knows how to diagnose, but also knows how to produce the health outcomes. How does actually we make sure that those health outcomes are delivered in our patients? I think that is the first change I want us to see. And I think if we start seeing that, then clearly we will impact on political factors or systemic factors in design of cares wherever we feel they are impeding in the production of those outcomes. And sometimes there are those political factors. We know that, and I think so. I don't think that we need to, I just feel that we need to become more empowered, I think, and you and I had this issue, right? When we sat in TMAC in our, which is the Trust Medical Advisory Committee, which was the body for us to interact with our hospital managers. And I think as clinicians, we often feel disempowered. We don't feel that we have that power to change systems. And I think that if we know that something will actually have an impact on the health outcomes of our patients, I think we need to say and speak up loudly and clearly. And so I think being that voice of the patient and feeling that it is our role, I think is where I want us to take us.
Okay, I'm not sure whether you answered my question about the developing world, but maybe you can.
Oh yeah, I'll come back to that. Yeah. Let me answer that as well. Yeah, no, I feel there's a lot to learn. I guess one of the things I am looking at the developing world, I think, is that we've known, like, for example, outcomes of schizophrenia, that we've seen such a mushrooming of early intervention services in the Western world, and yet outcomes often in the developing world have been in equal, without those services. And I think there's a lot to be learned, I think, as to what are those. I mean, I say this all the time about community psychiatry in the West, that we talk about community psychiatry, but often the belief is that a doctor and a nurse and a social worker will make up your community. Often there is no real sense of community. Even now, you must have seen this in Derby. Even now, I can go sometimes to a patient where their bedroom is full of takeaway boxes. Last 10 years, they've been accumulated, and nobody's knocked on the door to say, what's going on, mate? Like, how has this happened? Now, I feel that would not happen in this country. At least I would like to believe in India. I don't think it would happen. Somebody would knock on the door and say, what's going on? How can I help? And I feel that how do we learn from that, I think is important for the so-called developed world as well,
Seshni, can you just talk?
Yes, yes, thank you, Reena, and thank you, Professor Subodh. That was a brilliant and excellent talk. There were so many messages that I've taken from that, and as always, really grateful to you for supporting this conference, and Reena, despite your busyness of being the Dean of the Royal College and also traveling and running. Well done on that. So yeah, in terms of, I do agree with a lot what you've mentioned, and I had some questions, a lot of questions actually, but I'm going to narrow it down. There was questions on comorbidity, and I think Professor Satori has also mentioned about that, and I agree with that. I agree with what you've said about us considering, the roles of social workers and also bringing that into our management, our holistic management. And then I think in terms of the health inequalities, I'm really impressed with what you and Kamal are going to be doing, because the paper that was released earlier this year looked into inequalities, and especially into the BAME communities, and also it identified areas in mental health. So there were areas in the IAPT, areas in social workers, looking at how BAME communities were more likely, the kids were more likely to be referred to social workers and safeguarding. So I'm really impressed with that. So, but I think you've managed to explain some of it. The question that I did have is about stigma. So in terms of stigma in public mental health, I think as clinicians, we also need to be mindful there is that stigma. So how do we deal with it in our practice? How do we deal it with education and raising awareness as well? And I think in the public mental health setting and education.
So that's a great question, Seshni. I think you're right. I think there are two aspects of this stigma. I think so. Stigma is clearly attitudes matter, and I think how those attitudes shape people's behaviors are important. And I think so. I think creating that awareness of the entire picture, I think, is important. I think I certainly feel that presenting an image of psychiatry um, to the wider public that explains what psychiatry actually does is quite an important element of addressing the stigma. And I feel that as a dean of the Royal College of Psychiatrists, I do feel that I think even now when I go to schools, sixth form schools, etc., even medical students in year one, sometimes they don't really understand the difference between a psychologist and psychiatrist. And I think I have all respect in the world for my psychology colleagues and other colleagues, but I do feel that as psychiatrists, we have to see ourselves as the one branch of medicine and science that is bringing that holistic synthesis to our work, and then that's where I think I really resist the idea that a psychiatrist is just a prescriber, a medical prescriber, and I feel that that is a real risk to our profession, and certain parts of the world, again, I think because of the pressures they are in, it may be easier to kind of adopt that role and then think that, well, let's just see psychiatrists as medical prescribers. I feel that those kind of approaches will actually worsen the stigma that mental illness has, and worsen stigma about psychiatrists. I feel that, I think all the jokes that we, when I first moved to the UK, I thought that somehow there would be fewer jokes about psychiatrists when I moved to the UK. And I realized that was completely wrong. The same jokes that I heard about psychiatrists who were following me. So I feel that we have to own that space proudly, this idea that psychiatry is a fuzzy science. I think we need to own that space that, well, we are the branch of medicine that is asking the difficult questions. How does the psychosocial world actually impact on the biological world? We are the branch of science that is answering those difficult questions. And we have to own that space proudly. I think that is a very important element of stigma. So for me, I think that's going to be a big part. The second element, I think, is about discrimination. I think a lot of the times we forget the stigma causes stigma because there are real outcomes of stigma. I think because there is real discrimination, and we can see that around us. I think how many of us would own up to having a mental illness in our own workplace, and I think some of us might not do that because it actually would have a negative consequence. And so I think for us to challenge that discrimination is absolutely important too. So I think those are the two elements that I'd like to kind of focus on Seshni.
Can I ask Rohit, do you want to come up and ask the question, or do you want me to read your question? Right, I don't know. Okay, I asked the question for Rohit Walwalkar. He would like to know what does the future hold for perinatal mental health in the context of public mental health?
So that's a really good question. Interesting. I think it's a specific question. It's not my area of expertise. Certainly perinatal mental health isn't. But I think what we are realizing is that to again have a very narrow view of, I think a lot of the times people ask this question that, if we keep having the subdivisions, fragmented services work well, but how do we actually bring about improvement and some kind of efficiencies? And so an interesting experiment is probably happening in the UK. What's happening is that we are now developing what are known as integrated care services. And what this integrated care services will do is that for a whole borough, so say for a population of about 2 million people, there is a board that is responsible for all the health outcomes of all the people in that borough. What we will now see, for example, is in Birmingham, where I live, that there will be a single medical director, a single chief executive, and a single board that will be responsible for the health outcomes of all the people. And so if you take the example of perinatal mental health care, then I think if I'm sitting there and designing the perinatal mental health system for that, for the whole of Birmingham, then I have to start thinking that, well, what will actually improve the health outcomes for all my patients? And that will then make you think in a very different way, because then you think, what do I need to do at the primary healthcare level? What do I need to do to improve my midwives, their awareness of ability to spot mental health issues very early on? What do I need to improve in my obstetricians understanding and knowledge and skills? And so I feel that integration, that pathway will, I think, change subtly but significantly, because right now mental health sits alone, and it's a parental psychiatry that is then trying to influence the parental mental health for all the people, but it doesn't really have the levers to work with primary care, to work with acute healthcare, to work with the emergency department, etc. So I feel that the design of that integrated healthcare will probably help. A second development that's happening, I think, increasingly across UK, but also in other parts of the world, is the specialism of public mental health. So I think, while I've been talking about public mental health, we are now actually beginning to see people being employed in those roles. And I feel that that specialism will emerge, I think, and we will see public mental health consultants increasingly being employed to help design those health systems. And then certainly they will have an impact on those particular niche areas, Rohit, that you mentioned, like